Alrighty, hello and welcome everybody to our webisode. Today we are weighing in on different weight loss interventions. My name is Emily Berry. I'm a health services specialist here at Geisinger. And with me here today, I have Dr. Christopher Still. He is the Director of Nutrition and Weight Management here at Geisinger. So today we are going to explore the emerging anti-obesity medications and really delve into different intervention options, including surgery and lifestyle management. Before we dive into all that fun stuff, I just want to give a quick disclaimer that the information being provided today is to increase your awareness and is not intended to be medical advice. And if you believe you have any medical conditions or specific questions regarding your health, we ask that you please see your physician for that. So, welcome, Dr. Still. Thank you so much for joining us today.
Thank you, Emily. Good afternoon, everyone. Thanks for joining. I love to talk about obesity. The only challenge is it's only 15 minutes, so I'll keep it to 15 minutes, I hope. And then the good news is we'll open it up to questions. So we're going to talk about medical and surgical treatment for obesity, implementing practical therapies into clinical practice. So let's see. These are my disclosures that shouldn't really affect this presentation. And you can just read the objectives of this presentation. So we're going to talk mainly about the new medications, but really diet, exercise, and behavior modification remain the cornerstone. However, it's really been a paradigm change in our thinking of eating patterns, behavior modifications, and physical activity. Before these newer medications, we would work on behavior modifications. Oh, do you really need to eat that? Or can you limit it to 2 or 3 times a week? And really now we're focusing on, because the medications and surgery are very effective, on better diet quality. Are you getting enough to eat? Are you getting enough fiber, protein, fluids? And what is your eating pattern? Is it a healthy eating pattern? And we also really focus, like we do with bariatric surgery patients, on physical activity, really to maintain lean body mass. And so I've been doing this almost 30 years, and this really has been a paradigm shift for obesity management and really comorbid medical problems in and of itself. So obesity affects all different organ systems. These are just some listed in red. Diabetes, sleep apnea, fatty liver disease, polycystic ovarian syndrome, degenerative joint disease, coronary artery disease. But the big thing was that, even a modest weight loss had significant impact on controlling these medical problems. So you don't need to lose 100 pounds to have significant impact. For instance, individuals with obstructive sleep apnea, a 20 to 25 pound weight loss decreases apneic episodes by 50%. Fatty liver disease, which is the #1 cause of liver transplantation in the country today, that same 20 to 25 pound weight loss normalizes AST and ALT, liver function studies, 50% of the time. And we know that just a modest decrease in weight has a significant increase in insulin sensitivity and glycemic control. And for degenerative arthritis, for every pound we takes off 5.4 pounds per square inch of pressure on our knees and joints. So the issue is that we know that modest weight loss is very, very beneficial. It's always been in losing at least 5 to 10% of the weight and keeping it off. And you'll see that we do, with the newer medications, the injectable, weekly injectable medications and bariatric surgery, we've been able to meet that effective, clinically effective weight loss goals. And as I said, minimum weight loss 3 to 5% is good, but really getting past that 10% weight loss is really important for maintaining the significant improvement in these cardiometabolic improvements. And you'll see before the weekly injectables, we really were not able to get greater than 10% weight loss on a regular basis. And this is why that 10% weight loss is really important. Basically, there's 2 types of weight distribution. And you've heard of this before, the apple and the pear. On the left-hand side, these are people that have more android type of obesity, more the apple. And it's defined in women with waist circumference greater than 35 or men with waist circumference greater than 40. They have that upper body weight distribution that is more visceral adipose tissue around our vital organs. And we know that individuals that carry our weight through our midsection, that puts them at much higher risk for cardiometabolic diseases, diabetes, sleep apnea, fatty liver disease. So we always hear about BMI, and BMI is good for population-based, but on an individual basis, for risk stratification, a simple waist circumference is important. And so you can see a 10% reduction in weight loss has a significant reduction of 30% of this visceral adipose tissue. And as I said, this visceral adipose tissue is the inflammation driver of a whole host of cardiometabolic diseases. So getting a 10% consistent weight loss is going to have your best cardiometabolic effect. Subcutaneous fat around the buttocks and hips, that's more gynoid or the pear shape. That's actually more genetically predisposed and much more cardiovascular beneficial. So those individuals usually have a much lower LDL cholesterol, lower incidence of diabetes, sleep apnea, and fatty liver disease. So by losing just a 10% weight loss, we significantly reduce cardiometabolic risk. So this is a slide that I think is important for realistic expectations. So on average, if we just look at diet and exercise, after 1 year's time of studies, we can lose about 3 to 5% weight loss. Some people lose more, some people lose less. But on average, just with diet and exercise, after 1 year, we lose about 3 to 5%. When we looked at the oral medications, what I call the second generation medications, if you remember long ago in the late 90s, fen-phen, that was the first generation of anti-obesity medications. Then we had the second generation, which are the phentermine and topiramate, naltrexone, bupropion, and the once-a-day liraglutide. On average, you get about 8% weight loss. As I said, some people lose more, some people lose less, but on average, it's about 8% weight loss. The semaglutide 2.4, this is the Wegovy that you've heard about, we get about 16% weight loss. So again, the first time consistently, we've been able to crack that 10% weight loss on a consistent basis. Tirzepatide, which is Zepbound, we get about 21% weight loss. And then to just put things in comparison, for a sleeve gastrectomy, it's about 25% weight loss, and a gastric bypass is about 32 to 33% weight loss. So I think this is really important in talking to patients and establishing realistic expectations. A lot of people want to come in, just do diet and exercise, but they want the efficacy of a sleeve gastrectomy. So on average, this is what you can expect with our tools in our toolbox. Where obesity treatment works, all but one medication acts centrally. So there is one medication called orlistat. It's you may have heard it called Zenical. It blocks 30% of all ingested fat. It's not absorbed in the bloodstream. It's really not well prescribed in this country because we are pretty good at decreasing fat content. It has nothing to do with the adipose tissue stored. It just blocks 30% of all ingested fat that we take in. All the other medications, including the injectable medications, and you can see GLP-1 here, it's a hormone produced by the L cells, the endocrine cells of the small intestine, that acts peripherally to help with glycemic control. That's why the GLP-1s are approved for diabetes, and they go centrally to decrease appetite, and they're very effective at decreasing appetite. You can see also with regards to bariatric surgery, there's hormones that are changed because of bariatric surgery that affect our satiety, all in the hypothalamus. So all obesity treatment is centrally acting with the exception of that orlistat or tetrahydrolipostatin of Zenical. So let's talk about the tools in our toolbox with regards to pharmacotherapy. The indication for pharmacotherapy is a body mass index of 27 with at least one comorbidity, such as diabetes, sleep apnea, fatty liver disease, or a body mass index of 30 alone. This really hasn't changed since way back in the 90s with regards to the criteria for consideration for anti-obesity medications. However, you can see that compared to diabetes, Patients with diabetes, about 86% of adults with type 2 diabetes receive pharmacotherapy. Given those indications of a body mass index of 27 with a comorbidity or 30 alone, less than 2% of patients are prescribed anti-obesity medications. It may increase a little more with the more popular injectables and more effective injectables, but it may go to 2%. I mean, it's still very, very low. The other thing I'll point out is that if you look at bariatric surgery, patients that undergo bariatric surgery, again, less than 2% of people that meet the criteria. So we do have a huge opportunity for obesity treatment based both on pharmacologic treatment and also surgical treatment. So as I said, these are the medications that we have, naltrexone and bupropion. You may know this as Contrave. So naltrexone and bupropion have been along for over 50 years. Bupropion is Wellbutrin. It's used for depression and smoking cessation. And naltrexone is an opioid antagonist. It blocks the opioid or reward center in the brain. That has been used for substance use disorder. We found that a combination of naltrexone and bupropion has been effective in decreasing appetite and decreasing cravings. Phentermine and topiramate, this is Qsymia. So phentermine has been around since the 1950s. It's a symptomatic amine, like a caffeine or a type of medication. And topiramate is medications that's used for chronic pain or seizure disorder. That has been shown to be, in combination, also effective for appetite. Then we have the GLP-1. So the GLP-1, as you recall, is that hormone, naturally occurring hormone that's produced in the small intestine that goes to the brain that decreases appetite. Liraglutide is the once daily GLP-1, and semaglutide is the Wegovy or Ozempic. So Ozempic is FDA approved for diabetes, and Wegovy is FDA approved for obesity management. And then we have the newest medication called tirzepatide. It's a combination of the GLP-1 and GIP, which is gastroinhibitor protein. That combination has been shown to be effective for weight loss as well. Two indications, Mounjaro is for diabetes and Zepbound is for weight management. And then, as I said, those are all centrally acting, and then the orlistat is the only non-centrally acting medication. So if we look, and these are not head-to-head, but these are the efficacy studies, you can see we really were not able to reach this 10% on a consistent basis until we got to the once weekly. And that would be semaglutide, the 2.4, the tirzepatide, or sleeve gastrectomy or bariatric surgery. All these other medications got better than the 5%, but it was always consistently less than that 10% weight loss. So this has really been a paradigm change for obesity treatment and cardiometabolic treatment. So in addition to just helping with appetite, the GLP-1, remember that's the hormone that's produced by the small intestine that goes to the brain, has been shown to help with other cardiometabolic issues. Fatty liver disease, which is the #1 cause of liver transplantation in the country today, has been shown to be very effective and will probably be the next on the market to treat fatty liver disease. It also has some side effects, though, of decreases gastric emptying. I'm going to talk about that in just a minute. You can see the effect on the brain is the decreased food intake and decrease the reward behavior. It also helps with insulin sensitivity, on the muscle. And it also has positive effects on the pancreas with regards to insulin sensitivity. It also, so this is the cardiometabolic, it also has to, with regards to glucose metabolism, semaglutide has also been effective in decreasing secondary cardiovascular events. It also has been shown to be helpful in chronic kidney disease. They're also looking at it for Alzheimer's treatment and also in substance use disorder. So this new class of medication, it's really not a new class, it's been around for over a dozen years for glycemic control, has really been looked at for multiple different organ system treatment. So this is looking at semaglutide. So this is the Wegovy. You can see their efficacy trials compared to placebo. It was about that 15.8 or almost 16% weight loss versus about 3% in the placebo. So this was over about 1,900 patients. And again, consistently seeing greater than that 10% weight loss. However, this is the double-edged sword. It is very effective in weight loss. It decreases our appetite greatly, but if you acutely stop it, your weight, 2/3 of the weight comes back within 1 year. It is so effective in decreasing appetite, you're not going to say, I'm not going to eat, I'm not going to eat. Our appetite comes back, and so does the weight within 1 year of acutely stopping these medications. So obesity is a chronic disease, just like any other chronic disease that needs to be treated chronically, because if you stop, your weight comes back. Very similar to if you're on a blood pressure medication, you stop your blood pressure medication, your blood pressure is going to go up. Or if you're on blood sugar medications, your blood sugar is going to go up. So tirzepatide is just a combination of the GLP-1 and GIP. Also, both of them are produced by the small intestine, and it goes to the brain that affects appetite. And these are just the efficacy of those. I showed you the 21% versus 3% in the placebo. Again, if you stop the tirzepatide abruptly, same thing happens. Weight gain occurs quickly because you're taking away that physiologic decrease in appetite. Tirzepatide, in addition to obesity and diabetes, was FDA approved in November for obstructive sleep apnea, moderate to severe obstructive sleep apnea with patients with overweight or obesity. There are significant or can be significant side effects, however. There's two contraindications to this medication. One is a personal or family history of a rare thyroid cancer called medullary thyroid cancer. And the other one is having a personal history of acute pancreatitis, which is inflammation of the pancreas. Those are two contraindications. The most common side effects are all GI related. As I said previously, these medications decrease gastric emptying, so increase in reflux, abdominal discomfort, nausea, constipation are the most common side effects of these medications. Although they're very common, the reason for discontinuation was very low. And I don't know why. It may just be that they're very effective in reducing in improving glycemic control and weight loss, that patients can deal with these. But those are the most common side effects, but discontinuation rates are quite low. Now, finally, let's just turn to bariatric surgery, which to date remains the most longitudinally sound treatment of obesity and its comorbid medical problems. Obesity criteria is a body mass index of 35 with one comorbidity. Remember, pharmacotherapy was 27, or a body mass index of 40 without. The most common reason for, as an obesity medicine specialist or internist, of considering bariatric surgery is the profound resolution of comorbid medical problems. It is very effective in decreasing and ameliorating obstructive sleep apnea, fatty liver disease, diabetes, osteoarthritis, and the like. These are the most common side effects, or these are the most common bariatric procedures. The sleeve gastrectomy. This is the most common done in the country, although here at Geisinger, the most common procedure is the gastric bypass, just because of our higher BMI and comorbid medical problems. The most malabsorptive procedure is the duodenal switch. We reserve that for the most highest BMI and the most compliant patient, because that has the most highest risk of malnutrition and vitamin deficiencies. 99% are done laparoscopically, and the length of stay is overnight. There are some nutritional deficiencies that can occur, so we recommend daily vitamin supplementation and B12. So my last slide is just managing expectations. As I said, you can see the lowest efficacy versus the highest efficacy. So diets, pharmacotherapy, and then the duodenal switch. People come in wanting to do a little bit of diet, a little bit of exercise, but they want the efficacy of the duodenal switch. So I think managing expectations are important, but the newer medications that are here, we are moving closer and closer to the long-term benefits of, like bariatric surgery. So these are just my conclusions. You can read through these, but I went over just a little bit from 15 minutes, so I'm happy to take any questions that you may have.
Yes, and thank you. That's okay that you went over. That happens. You had so much. I feel like we probably could have talked like an hour
Oh, yeah,
on this, to
I
be
could talk
honest, or
for
longer.
15 hours, yeah.
Yeah. Um, I did have a few questions for you. I
Mhm.
know you touched on individuals using GLP-1 medications or injectables for weight loss. Um, there's, at least from some of my friends or people I know, there's always that concern they talk about that potential weight gain, which you talked about, if they would discontinue the
Mhm.
medication. Do you have any guidance on strategies post that? So should they just cut cold turkey? Should they taper off? And if, or should they be on it for life, I guess is the next option. Any guidance around that?
So, yeah, that's an excellent question that I get a lot. And so there's two rules of thought. I view obesity as a chronic disease. And like I said, if your blood pressure is controlled, you don't stop your blood pressure. So we do recommend continuing long term because it's no fault of the patient. It is just so effective in decreasing appetite that once you stop, your appetite's going to come back. What we're seeing, though, is for the first time, we're getting patients down to a normal BMI. So we have to decrease the dose and then extend from, say, every 7 days to every 10 days to have them be at a stable weight. So the bigger issue that we're seeing clinically is changes in insurance, and that's devastating. So say that their insurance company is covering, and then all of a sudden they stop covering, then that's what we have to deal with. And then we go back and looking at the oral agents and try to mitigate that weight regain. But I think accountability in that case is really important because we try to mitigate that weight gain that we know 90% does come back.
Mm-hmm. No, great information. I think too from the Q&A here, we had a question more around insurance and these different interventions. So I'm not sure if you can answer this, but are these interventions, any of them, typically covered under our insurance, and especially injectables for those who may have stalled on past weight loss interventions as well. Anything, around
Yeah,
that?
so our health plan, so agnostic of insurance, our clinical enterprise has a specific protocol that nobody in the Geisinger system can prescribe GLP-1s unless they've had a body mass index of 35, a heart attack, stroke, or severe peripheral vascular disease. So, but that does not mean that patients don't have insurance because the state, the GHP family, they do have coverage. It's just unless they have those clinical enterprise criteria, nobody in the Geisinger system can prescribe them. So those regarding the injectables, and actually the health plan doesn't cover any of the oral agents as well. The health GHP family, they do cover some of the oral medications as well. The health plan does, as well as many insurances, do cover bariatric surgery, but not, it's very hit or miss on the what insurance cover the injectables.
Hmm. Yeah.
It's just because, at least currently, the significant cost. I mean, if you were to go out and pay for these, they're about $1,200 a month. And so, and so it just was unsustainable for the health plan, at least to date. They may change their clinical protocol. I'm not sure, but that's where we stand with regards to coverage,
Yeah.
unfortunately.
Thanks for explaining that because I feel like as I was prepping for this too, this is a question that came up quite often. Another question from the Q&A here. Um, is more focused at menopausal women who might struggle with weight gain despite exercise and diets. Is there any recommendations you have for them specifically, or maybe how do they determine the best intervention option, or just anyone in general? How do they?
Yeah, I mean, that's a difficult patient population because of physiologic changes. To date, I mean, before the GLP-1s, we'd always consider metformin, which is an insulin sensitizer to help through perimenopausal. but there's been some good studies looking at Contrave, which is that naltrexone bupropion in individuals perimenopausal, and also the GLP-1s. So yeah, I think there is treatment out there. It's just going back to that coverage for the treatment.
Mm-hmm. Yep. Thank you. Thank you for answering that. Are we able to possibly send out the slide deck to anyone who might be interested in viewing, Dr. Stowe?
Sure, I can send the PDF out, no problem.
Yeah, yeah, that would be great. Because if there is a question to look at the BMI slide again, so that might just be a good
Sure.
follow-up.
Just remember on
And
this BMI slides, this is what they're FDA approved. It doesn't mean that we have our insurance covers it, or your whatever insurance you have covers it. This is what's approved for it.
mhm. Let's see here. Just to be mindful of time, I feel like the time went so
I'm
fast.
sorry I went over a little bit.
Oh my gosh, you are fine. Um, I just wanted to end on the question just because we have 3 minutes left. That we gained a lot of knowledge today, right? Is there any resources or anywhere you can direct anyone interested in learning more about this? Any resources, any place you can direct if they're interested that you
Yeah,
can think of?
there's a very good patient-focused society called the Obesity Action Coalition, OAC. They have they're a patient advocacy group for patients with overweight and obesity. And they have a tremendous amount of educational materials, resources on their website that's all free. And so I'm one of the founding board members. For full disclosure, over 20 years ago, I'm not on the board now, but there is a really good, legitimate place that people can get information. The Obesity Action Coalition, or OAC.
Awesome. Okay. Thank you for that.
Sure.
Because I think a lot of the time we want to follow up with where can we learn more and so on. So that'd be great. We are just about running out of time here. I just want to note to everyone, if you have any specific questions regarding around your health that you do discuss with your doctor, they would be the best person to connect you with the specialty area or give you medical advice. Dr. So I want to thank you for joining us today, and also everyone who tuned in. I think this was a really great topic, and I feel like I've learned a lot as well. Dr. So you answered a bunch of my questions as as you went through.
Good. That's
So
good.
the presentation was great.
Well, thanks
And
for thinking of me.
of course, and in the
I'll send you
Q&A,
this PDF of this, and you can send it around, or however you
that
want
would
to
be
distribute.
wonderful.
Okay.
That would be wonderful. Thank you so much,
Thanks, everybody.
everyone who tuned in. Thank you so much. If you have any additional questions, feel free to send them to our wellness inbox. It's wellness@geisinger.edu. Next month for our well-being webisode, we're talking about summer safety. So feel free to tune into that as well. And we look forward to seeing you. And thank you again, Dr. Stowe. I appreciate it.
Thank you. Bye-bye.
Bye, everyone. Have a good one.